Thank you. So my presentation will be in another direction. We already talked about efficacy of antidepressants in adults and children. Now we will see something, let's say, more basic about genetics. But don't be worried, because people is always worried when we are talking about genetics. I will try to be as much simple as possible. So in my presentation, I will start simple, get complicated, and finish more simple. Start simple means this is what we do now. When we have to treat a patient with depression, we choose a drug, but we don't know which drug we can choose. The patient will respond to sertraline, will respond to citalopram, to escitalopram, we don't know. So we try. So more than half of the patients we have to change treatment after 1 month because they don't respond. So it would be very useful to know in advance patients who respond to treatment. And there are some studies about clinical predictors of response. This is one large European study. Also, we worked on the large American STAR-D trial, 4,000 patients, and we identified some predictors, clinical predictors, that are the obvious ones. People with high education, or more income, not living alone, or with good employment status, they respond a little bit better. But still, this is not sufficient. It would be much more useful to have exact predictors of response and tolerability of drugs. This is what is the aim of pharmacogenetics. This is what the aim of this presentation. We will try to see how it is possible to identify a specific genetic profile of our patients so we can choose the right drug, the right dosage, to achieve maximum benefit for the patient with less damage as possible. Already there are some evidence in this direction. Already there are some regulations also in this direction. The American FDA issued a warning about treating Asian patients with carbamazepine because if some of them have a specific genotype, they can have a very severe skin allergic reaction. And of course, we also know all the pharmacokinetic aspects, that means metabolizing enzymes. It is already in the label of many drugs that you should know, and probably not all of us is aware of this, but it's already in the label in America and Europe, is already in the label of drugs that we should know the genotype of our patients for the metabolizing liver enzymes, because some patients are rapid metabolizers, others are slow metabolizers, and so the plasma level of the drug is different, and so the dose must be different. So something is already there in terms of pharmacogenetics. We know one gene for carbamazepine, we know the metabolizing genes for all the other patients, but still is not sufficient. We would like to know more in detail. We would like to know more genes. We would like to create a profile to predict response and tolerability. And therefore, which are the genes that are involved in antidepressant response and tolerability? The usual primary suspect is the serotonin transporter, where almost all antidepressants go. Almost all, because not all of them, of course. SSRI block the serotonin transporter. Many tricyclics also block the serotonin transporter. Therefore, the gene coding for the serotonin transporter is the primary suspect for variation in response to antidepressant treatment. Therefore, we can hypothesize that some patients will have a gene that is coding for the so-called short variant of the serotonin transporter, and those patients, it's not only patients, also us, half of the population, about half of the population has a gene that is coding for a reduced number of serotonin transporter in the brain. compared to the other half, more or less, of the population who has more serotonin transporter in their brain. And this reflects to a different functioning of the brain, as you will see later. 15 years ago, we published this paper where we saw, indeed, that patients with the short variant of the gene had a much worse response compared to patients with both long variants. This was the first pharmacogenetic finding in antidepressant efficacy. After 15 years, this is the most recent meta-analysis, the finding has been replicated in almost all samples that performed such a study. And therefore, it is almost quite accepted now that patients with the short variant of the serotonin transporter respond less to antidepressants. So this is still simple. Remember the objective: to predict antidepressant response. Clinical factors are not sufficient. Genetic factors, we are identifying some genetic factors. The first strong genetic factor for antidepressant response is the serotonin transporter gene, which in its short variant is associated with a clearly defined worse response. But let's go a little bit in a more complicated issue. It's not that simple. Why patients with the short variant of the serotonin transporter respond less to antidepressants? Because they have less serotonin transporter in the brain? Not so simple. Not so simple, because this is probably due to a much more complex and indirect effect in those patients. What is this complex and indirect effect? Imagine patients that are born with the short variant of serotonin transporter, and therefore they have a different brain. They have a brain that has a different anatomical feature in terms of hippocampus and amygdala, different temperament, different reactivity to stress, different risk of developing mood disorder, and therefore, finally, a reduced response to antidepressants because they have a poor serotonin pathway plasticity. So this is what I was meaning when I was telling it is a little bit more complicated. So the gene variant, short variant, is influencing the number of serotonin transporter in our brains that is giving our brain a reduced plasticity. This reduced plasticity is the reason why patients don't respond to antidepressants, because antidepressants, to work, when they have their antidepressant effect, they have a plastic effect in the brain. They change the hippocampus. They change the functionality of the frontal cortex. And if a patient has an insufficient plasticity of the brain, antidepressants don't work or work less. So this is the story of the serotonin transporter. But it is also useful to think how we can use this in clinical practice. In this paper, we try to also hypothesize a clinical application. There are already 2 or 3 universities in the world that already are using the genetic identification of the short variant of the serotonin transporter to predict specifically patients who will respond to SSRI. And if they have the short variant, you can prescribe a noradrenergic antidepressant, for example, or dopaminergic. And in this paper, we demonstrated that we have an economic benefit if we do it. So even considering only one gene, serotonin transporter, if we make a specific prediction for each patient and tell if they will respond or not, we will save money, because we will save time in terms of antidepressant response. This is a review that is telling us that not only the serotonin transporter, here you see all the positive studies, all the plus are all the positive studies. It means studies, you see how many, where there was a clear association between the short variant and the response. Of course, there are also negative studies, because things are complicated, as I told you. Let's finish the story of the serotonin transporter. There are other genes in the serotonin pathway, but not only. Also in the developmental area of the brain, enzymes, COMT and MAOA, that we will see also later regarding psychotherapy. So there are many genes. We already have evidence of many genes influencing antidepressant response and others. Recently, other groups also tried to do a different approach, not only look at one gene by one, but look at the whole genome. 3 big groups in the world are doing this kind of studies. I will not go into detail. And also these kind of studies are leading us to identifying some specific genetic variant. In particular, we focused in the big STAR-D American trial on a specific phenotype that is early response. We know that early response can be different from late response. Therefore, we identified a specific gene in the glutamatergic system that can be associated with early response. Let's be a little bit more complicated. Antidepressant response is controlled by many genes, each of them with a complicated and indirect effect on the brain of our patient. But not only, there is also the environment. In this paper, a few years ago, we considered that patients with a stressful environment have a worse response compared to patients with a positive environment. And this interacts in terms of genetic background, gene-environment interaction. And so for the last part of the presentation, we will shift to psychotherapy. This is a complicated issue. We are talking about antidepressants that influence antidepressant response through neurobiological factors, but this is also mediated by the personality of the patient, by environment of the patient, and by the genetic background. So we know that genetic factors are quite important. About half of the variance, it means 50% of the reason why a patient responds is due to genetic factors. The other half, of course, is due to environment. So the situation is quite complex, as you see. And what about psychotherapy then? Psychotherapy influences the brain in a very similar way as drugs do. The final outcome is the same. When a patient responds to antidepressants, the patient has an improvement of the function of the hippocampus. And this is exactly what happens when patients is treated with psychotherapy. This is why when you combine antidepressant and psychotherapy, you have an improved efficacy, because you follow 2 different pathways to obtain a common final aim, hippocampus recovery. Therefore, the same genetic variant that has been investigated in antidepressant response have also been investigated in psychotherapy response. There are much less studies compared to antidepressants, because about antidepressants we have about 200, 300 studies. For psychotherapy we have less than 10. Despite that, and despite the fact that psychotherapy here is not only in depression but also in anxiety, the first gene, the most famous one, the serotonin transporter, is also influencing cognitive behavioral therapy efficacy, in this case in anxiety disorders. Serotonin transporter, influencing both antidepressant efficacy and cognitive behavioral therapy. It could be surprising because you could think, how it's possible? SSRI block the serotonin transporter, but cognitive behavioral therapy is not blocking the serotonin transporter. But as I told you before, serotonin transporter gene is modulating the flexibility, the plasticity of the brain. So if you have a plastic brain, you will respond easily, in a better way, both to antidepressants and to psychotherapy. Another gene is the COMT. COMT is metabolizing the monoamines in the brain it is influencing antidepressant response, it is influencing in the same direction psychotherapy. In this case, again, cognitive behavioral therapy. In the same direction, couple of studies. Another enzyme, monoamine oxidase. Again, in anxiety, it is influencing cognitive behavioral therapy efficacy in the same direction as it influences antidepressant response. Finally, another gene that is linked to neurodevelopment, again, influencing, I will not go into detail, cognitive behavioral therapy. So you see what happens. Some genes influence antidepressant response. The same genes influence psychotherapy efficacy. This is not surprising because the mechanisms are very, very similar with antidepressants or psychotherapy, in this case, cognitive behavioral therapy, and some negative findings, of course. So the last point of my presentation is, as I promised you at the beginning, to get it more simple. The future could be as simple as this is already in the field of oncology. We could have a specific profile, specific genetic profile, here is called recurrence score, a specific genetic profile that is predicting what? In this case, is predicting recurrence of breast cancer in oncology. But we will have the same in predicting antidepressant efficacy and psychotherapy efficacy. If we combine the serotonin transporter, the COMT variant, MAO-A, BDNF, and some other genes, we will have a curve where all patients will be positioned in any point of the curve. So we will have some patients with all favorable variants. We will have a very high rate of response. And we will have patients with a combination of all negative variants with a very low rate of response, and then intermediate situations, of course. So this could be the outcome of our genetic studies, a prediction of response. So prediction of antidepressants and psychotherapy response using clinical factors is not sufficient. A complex interaction is existing between genes, environment, personality, and what happens to the plasticity of the brain. So I'm sure that in a few years we will have the possibility to apply in clinical practice the genetic profile to improve the response of our patients. Thank you for your attention.